Good evening, everyone, and welcome to this virtual discussion. My name is Rue Tagger, and I'm one of the Executive Vice Presidents here at Sunnybrook. It's a pleasure for me to kick off the first event of Sunnybrook's Virtual Impact Series. Today, our focus is to discuss advancements in cardiac care, and this pertains to the work of Sunnybrook's Schulich Heart Program. Over the next hour, we'll hear from some of our top experts who are bringing the future of cardiac care to our patients. The area of cardiac care is ever changing, and in large part, this is related to new technology. And some of this new technology was first introduced to Canada right here at Sunnybrook. For example, 11 years ago, we introduced a new procedure called a transcatheter aortic valve implantation, otherwise known as the TAVI procedure, to our structural heart program. One of our experts, Dr. Harindra Wejasundra, will speak more about this procedure. And this new procedure actually eliminates the need for some patients requiring complex or lengthy heart surgeries to treat certain heart conditions. At first, the TAVI program was entirely supported by donors. And within 3 short years of demonstrated success, government was sufficiently convinced that this is a procedure that needs to be made available more broadly. And supported with government funding, Dr. Wejasundra was able to help government to make policy decisions about who this procedure should be made available to and how to distribute or make this procedure accessible. So Dr. Wejasundra, if you could just sort of flag to the audience who you are. He's an interventional cardiologist and just recently has become our program chief of the Schulich Heart Program. We'll also hear from Dr. Benedict Glover. He's our director of the Arrhythmia Services Program at the Schulich Heart Program. Ben, could you please give us a wave? In the province, 1 of every 10 patients with a heart arrhythmia is treated at Sunnybrook. And Dr. Glover will explain more about what an arrhythmia is and some of the new advancements in this field. Despite supporting one of the highest caseloads in the country, Dr. Glover's team is challenged to keep pace with demand. This is why we are actively fundraising to expand and renovate to create 2 new procedure labs, which will allow us to double the amount of procedures that we do in this area. We'll also hear from Dr. Gideon Cohen, head of cardiac surgery within the Schulich Heart Program. Gideon, can you wave to us? Thanks. Dr. Cohen is one of 175 cardiac surgeons in Canada. He has performed thousands of cardiac procedures, as well as conducting a lot of research. He'll tell us more about how his team is integrating minimally invasive techniques into their work. Our panelists are just a few of the experts who make up one of our top heart programs in the country. So if you were to ask me what makes the Schulich Heart Program so special, I would say it's because our team always looks beyond the practice of medicine with a vision to invent the future of cardiac care. But I'd like you to judge that for yourself. So let's begin our discussion with our experts. So, Dr. Wejasundra, could you speak to us about your work in TAVI? And specifically, can you explain what the procedure is and who should have this procedure?
Thanks, Rue, and thank you all of you for joining this call. So the TAVI procedure is focused on valve disease. So the heart valves are the doors that separate the chambers of the heart. And TAVI is focused on the aortic valve, which is the main door that opens and closes with each heartbeat and gets blood to flow into the rest of the body. As patients get older, that door starts opening less well and gets stuck. And as that happens, they can start developing symptoms and in fact has a very poor outlook. About half of patients will die within 1 to 2 years, so quite a serious condition. It's a mechanical problem that unfortunately medicines don't fix. The valve needs to be replaced. And traditionally, the treatment has been open heart surgery, which works very well, but unfortunately, because it is a big surgery, about half of patients can't get it. And hence there was this real big unmet need. And that's where TAVI fit in. And we can see a TAVI valve there. We have a short animation to show you what a TAVI procedure actually looks like. So in fact, we do these procedures in our cath lab with the patients awake with sedation, often they're speaking to us. We go up through an artery in their leg, snake our valve up, that you can see it going up all the way to the tight heart valve. And then we open up the valve. These new valves allow us to reposition it so that we can get an absolutely perfect position. And once it's in place and we're happy, the procedure is done and we close the tiny hole in the patient's leg. From the time we make that hole to when we finish the procedure takes about 40 minutes. So a remarkable procedure that takes place while patients are awake. And as you mentioned, over the last decade, it has moved from being a procedure that we used only in patients who couldn't have cardiac surgery, and that was completely kickstarted by philanthropic funds, that has moved now to include patients who are high risk, patients who are at medium risk and at low risk. And Sunnybrook has been very fortunate that we've been one of the few Canadian sites that have been able to participate in these trials. We've played really a seminal role in trying to convince policy to change, and now at the lead site for actually working with government to see how we can make sure that funding is such that this is affordable and it is accessible to everybody.
Thanks for that. So a question we hear a lot from patients is TAVI always better? Can you comment on that?
Well, certainly for the elderly patient, the advantage of TAVI is that we really design it so that the procedure itself and the hospital itself has the least impact on the patient. It's done when they're awake. They're usually sitting at 4 hours. They're up and walking that evening, and they go home the next day. And so the recovery is remarkably quick, which is important for patients who are elderly. We know that with the large studies that we've participated on, a TAVI is as good as the traditional gold standard of surgery for the vast majority of patients. And importantly, we also know that it's affordable. And certainly when we perform these procedures at Sunnybrook, we're able to do it at a cost that's equal to cardiac surgery. Is it the best for everybody? No. There are younger patients who are born with a different type of door. Instead of having the traditional door, they have congenital problems with their heart valve. And those younger patients, certainly traditional cardiac surgery is the better option. And the final unknown or Achilles heel is we don't know how long a TAVI valve will last. We know it'll last at least 7 years, probably 10 years. And so that question of durability is still there. And there is just so much more experience with traditional open heart surgery as far as the longer term results. So for younger patients, still better choice is cardiac surgery.
So I did mention earlier that we were leading in this field. Can you elaborate more about why we are leading in this field?
Absolutely. So we're fortunate that we are a large program. So we do between 300 to 350 of these procedures. We're the largest program in Ontario. We're the second or third largest program in the country. We're a mature program. And that maturity has come from the fact that really brings me an enormous amount of pride that the TAVI program is one example in the Schulich program where we have pushed for innovation, not just with device development, which we have, but really all the way through to getting these devices into patients in a way that's affordable. We've talked a little bit about the trials that we participated on. We've had a number of firsts in our program. We were the first in the country to use a special device during a TAVI to protect the brain, to prevent strokes. We were the first to look at a way of altering the valve to optimize the results. Not only have we been the first in developing these procedures and doing them, but we've been a real leader in teaching them to others. So the director of our cardiac cath lab, Dr. Sam Radhakrishnan, is an international proctor. And over half of the programs in this country were taught to do the procedure by him. He's taught people in Japan, in India how to do this. So not only do we develop these, but we teach them. And finally, it is really critical to be able to get these out into the community. And by impacting policy, we ensure not only that we develop these techniques, but they are accessible to everybody. You know, I'm fortunate that I'm the spokesperson for a large team of people in the TAVI team. There are 2 cardiac surgeons, 2 cardiologists, a nurse practitioner, administrative support, and just an enormous number of people that really are equal members of this team. And one of the reasons that we've been able to lead, and this has been just such an amazing 10-year experience, is that we are well recognized as a high functioning team where everybody is proud of their role, but truly the sum of our parts is more than the whole. And that's why we've been so successful.
Thanks for that. So it is really incredible to see how the program has grown and the leadership that we've shown within the healthcare system as it relates to this work. I do want to mention that just recently the team treated the first patient with same day TAVI. So it's the first time we've actually had a patient where we've been able to treat them within one day and send them home. And I recall that years ago when we started this procedure, these patients were staying in our hospital for about 5 days or so. So we've come a long way in our ability to effectively treat these patients, and we're making improvements all the time. So Harindra, thank you for sharing this information with us. So let's go to Dr. Glover now and talk a little bit more about the Arrhythmia Services Program. So Dr. Glover, for the purpose of those who may not know, can you explain what we mean when we say arrhythmia services? What's an arrhythmia? Ben, if you can just unmute yourself.
Thank you very much, Rui, for this evening, and thank you to everyone who's joined us this evening. It's a real pleasure to be here to discuss our arrhythmia services. An arrhythmia is essentially a short circuit within the heart. It's whenever some of the tissue in the heart fires off really rapidly, and it causes the heart to go very, very fast. And it can cause considerable symptoms to patients. It can cause dizziness, lightheadedness, fatigue, palpitations, heart failure at its worst. And conventionally, it's been treated with medications. And the unfortunate thing about the medications for arrhythmias are that they're really quite old. I mean, there hasn't been any new developments in drug therapy for arrhythmias in the last 10 to 15 years. So a lot of the drugs have considerable side effects. And that's why we have really kind of pushed forward with technology and ablations as a way to treat arrhythmias. The overall service in terms of managing arrhythmias is looking at Holter monitors, ECGs, assessing our patients in the clinic, and then really triaging them through to whether they would undergo a catheter ablation or not. Arrhythmias are becoming more common. There's no doubt about it. That's probably for various reasons. One is that the population are living longer, so therefore a lot of these arrhythmias are age related. The longer you live, the more likely you are to have some sort of an arrhythmia. We're probably detecting a lot more because a lot of patients now have iWatches, Apple Watches, AliveCore monitors, and a lot of my patients can actually transmit their ECGs up to my office. Some of my patients can come into my office and actually do their own ECG right in front of me. I don't even have to feel their pulse anymore. So patients can self-diagnose, and then we're just doing more tests in general, in general practice. So there's a lot more patients being referred to us than there was 5 years ago, 10 years ago, and certainly 20 years ago.
Great, thanks, Ben. So a cardiac ablation is a procedure, or one of the ways in which you commonly treat an arrhythmia. Can you tell us how an ablation procedure is performed and why it's necessary?
Yeah, thanks for that question. So a catheter ablation is essentially where we can put a little very fine wire in through the femoral vein at the top of the leg, and it threads all the way up through the inside. It kind of floats up itself into the heart, and we can locate the source of those short circuits, and then we can deliver energy to the short circuit and destroy it, and therefore effectively treat the short circuit. And I've got a little model here of the heart just to kind of demonstrate. The heart sits in the chest in a kind of an oblique manner, and we go up from the inside. And if it's on the left side, we actually go across from the right to the left, which is where a lot of the arrhythmias occur. We record lots of electrical points inside the heart, and then we've got the exact point, and it is very, very accurate. When we've got the exact point within 1 to 2 millimeters, we can deliver our energy and effectively terminate the arrhythmia. We perform a high volume of catheter ablations here in Sunnybrook. We're very proud with the technology that we use, but maybe something that is more useful to answer that question would be just to talk about one of our patients and what the patient experienced. And this particular patient is a good example of many patients that come through our services here at Schulich Heart. Jim was a patient who actually lived outside the GTA. We serve the GTA well here, but we also serve the entire province of Ontario, which is important to remember. Jim lived outside of the GTA. He was otherwise well. He actually became unwell very, very quickly. He developed atrial fibrillation, which is a very common arrhythmia, which originates from the top left chamber of the heart. It's one of the most common arrhythmias which we treat in clinical practice. His heart went very, very fast. He actually ended up in resus in the emergency room. He ended up in intensive care in his local hospital, and he was diagnosed with atrial fibrillation. He was started on medication by his physicians, and he was essentially told, that's it, you're on medication. You're going to remain in this arrhythmia for the rest of your life. He's not an old individual. He was told, this is for the rest of your life. That's it. That's your treatment. And I think, a lot of people may accept that, but Jim and his wife didn't accept that. They actually did a bit of research. They went on the internet and they looked around to see other centers where maybe someone could deliver a little bit more care. They actually wanted a better outcome, and we at Sunnybrook can deliver that better care. We can deliver a much better outcome. They sought us out. Jim came down. He had his catheter ablation, which is performed in a minimally invasive method all through the groin. He was discharged the following day. He is no longer on any of the medications which he was put on at the start. He is in normal sinus rhythm. His wife says that his life has totally transformed from a period of darkness, depression, and despair, and he's a different person. So that's a very good example, and we have permission from Jim just to play a short video just to describe his experience in terms of how this changed his life.
February of 2018, I ended up in the emergency room at Belleville General Hospital. I was in uncontrolled AFib. My heart rate was over 210. They rushed me straight to the Red Room where they administered drugs, and I was diagnosed as being in uncontrolled AFib with heart failure and kidney failure as a result of that. I was in a very dark place. I had pulled back from my emotions. I was feeling very, very sad. This is hard for me. I stopped talking to our children because I couldn't bear to think of a life without their future or my future in it. I was feeling weak. I couldn't work. I had to reduce my hours at work dramatically. And I just was a shell of myself at that point. I don't have a lot of memories of that time, but that he recommended that Dr. Glover was the best. We took that as a sign that this would be a chance to get our lives back. We saw Dr. Glover in the fall of 2018. He scheduled an ablation surgery for February of 2019. I went ahead with the procedure gladly and with lots of gratitude to Dr. Glover and to Sunnybrook. The operation worked. I was now in sinus rhythm, and my heart was feeling normal again. We got our future back. We started planning trips. It took a while to feel a lot better. I'm feeling a lot better now. I've emotionally reconnected with our children, and with my wife, and I'm getting back to work. And I have so much gratitude to Dr. Glover and Sunnybrook Hospital. They gave me my future back. Thank you, Dr. Glover. And thank you, Sunnybrook Hospital.
Thanks, Ben. The video really does give us a good understanding about how this type of care can really be life-altering for patients. So here's another question for you. So I understand your team is leading the way in terms of the use of new technologies. Can you tell us more about some recent exciting firsts for your program?
Yeah, thanks for that. And that was a very emotional video. We are, one of the few centers that actually performs these procedures. These procedures are only performed in high volume academic centers. Even out of all of those centers, we feel that we are leading the edge in terms of the technology. We have a very good translational center here, so we can actually perform preclinical work, and we can actually use technology even before it's brought to the clinical arena, which is excellent. We are one of the first centers to use a very high definition mapping system, and we're the first to look at a very specific electrical activity within the heart. Conventionally, whenever we move these wires inside the heart, we use X-rays, which gives you like a two-dimensional image of the heart. It's a very basic way to look at the heart. We don't really use X-rays anymore. We have them solely as a backup. We use a very sophisticated electroanatomical mapping system, which is like a GPS system. So this is a little bit like going from a paper map to a GPS when you're driving your car. It's two different technologies. Whenever someone has an ECG performed in the hospital, it records 12 electrical points inside their heart. Whenever we record activity now inside the heart in Sunnybrook, we record 20,000 electrical points. And with the technology that we have, we can record that in approximately 15 minutes. So the density of electrical information that we have is incredible. And I think that these are the kinds of things that we're really proud of. It's amazing that the technology that we have really does determine the outcomes that we get for our patients.
Wow, that's really amazing. So there's a lot of hope for the future in terms of the work that we're doing here at Sunnybrook. Can you talk a little bit more about what the future holds for arrhythmia care?
Yeah, so thankfully, arrhythmia care here is high priority, and I'm very grateful for that. We're actually currently looking to build another electrophysiology laboratory. And what an electrophysiology laboratory is, it's a very sophisticated cardiac catheterization laboratory, very expensive, but very sophisticated with lots of technology. We currently perform approximately 15 to 20 catheter ablations per week in one laboratory. That's the tip of the iceberg in terms of what we can actually do for our patients. Therefore, we want to double the volume, and we're hoping to build a second laboratory. What does that mean? It means that patients should not have to wait as long as they do. These arrhythmias are time sensitive, so if you leave them longer, they're more difficult to treat. If you leave them longer, the results for a catheter ablation are more challenging. And one of the things I always say to the patient when I first meet them is often, I wish I had have seen you before, or I wish I had have seen you a year ago. So the quicker we can get our patients in and have these procedures, the more successful these procedures are going to be. And we're really, some of the technology that's coming through in the next 1 to 2 years, which is the time frame of this new lab, is incredible. It's really amazing. We're going from a totally different energy source that we use to destroy the arrhythmias. We're moving towards that, which is just incredible. And maybe I can also just show you a short video of some other technology that we're using in our lab that we're working on. This is a 3D hologram of the heart. So this is actually the left atrium. This is the top left chamber of the heart. And this is exactly what it looks like inside the patient is on the table. This is suspended in air. We can see this in 3 dimensions. We can rotate the image by talking to the image. And whenever we put the wires inside the heart, we can now localize where the wires are, and we'll be able to see where we deliver our 3D lesions. So this is 3D at its most, and you can see how we can move that. We basically wear 3D glasses to visualize this, and this is real-time anatomy, which is all being gathered from inside the heart during the procedure. No one else in the world is doing this at the moment.
Wow, that's pretty inspiring. Thanks, Ben, for giving us a closer look at the work that you do with your team.
Thank you so much.
So why don't we talk to Dr. Gideon Cohen now? So he is the chief of our cardiac surgical program. So Dr. Cohen, we've talked about a number of innovative procedures, and a lot of them are related to minimally invasive care. Can you reflect on how the role of a cardiac surgeon is changing?
Sure, and thanks, Drew, and good evening, everyone, and thanks for taking the time tonight to join us. Thanks for the foundation for putting this together as well. So how has the role of the cardiac surgeon changed? A great question. You know, when I started, there was a clear distinction between surgeon and interventional cardiologists. And now with time, the lines have blurred as our job descriptions have started to overlap somewhat. Now cardiologists are addressing pathologies that were once the sole purview of cardiac surgeons, and now cardiac surgeons are spending time doing procedures in the cath lab, a part of the hospital which was previously foreign to them. You know, why this transition? Because the new technologies that we're now developing demand a combined expertise. So much so that that the training of new surgeons is changing in order to address this need. In fact, there are actually some specialists out there who've trained in both cardiac surgery and interventional cardiology. Now, that may be a bit of overkill, but that's the way this especially is heading. You know, to give you an example, I spend 3 days a week in the operating room doing conventional open operations, and 1 day a week in the cath lab doing catheter-based interventions, where I was today actually with my cardiology colleagues, which I enjoy immensely. So I'm now a part of a bigger team, which is very different than was the case in the past. The other way in which my job has changed has been in terms of expectations. And what do I mean by that? But, well, you know, naturally, some of this push towards more minimally invasive approaches has spilled over into the operating room. So even in the OR, there's now an expectation of doing things not only more minimally invasively, but also more safely. So we're now applying advanced technologies for open surgeries as well. There are procedures and technologies we now offer which we couldn't have even dreamt of offering only 10 years ago. Things like performing coronary bypass surgery through a small incision in the chest, you know, 5-centimeter incision rather than a full chest opening. Hybrid revascularization, where we can perform one bypass through a small incision and complete the revascularization or opening up of the blocked arteries with catheters. We're now building a hybrid operating suite where we can do surgery and catheter-based procedures at the same sitting, so we can transition from one procedure to the next in the same room. We can perform mitral valve repairs. Mitral valve is another valve in the heart where we conventionally repair through an open chest incision. Now we can do it through a very small window on the side of the chest. And finally, things like sutureless aortic valve replacement, where we were the first in Canada to provide this technology. Just to give you an idea, the conventional aortic valve is implanted by opening the chest, removing the native valve, and then placing a number of about 15 sutures in the base of the heart, inserting those sutures into the new valve, parachuting that valve down into the heart, tying all the sutures. So you can imagine that whole process takes quite a while. So I'm going to show you a quick video, and I've been asked to put forth a bit of a disclaimer that this video may be a bit graphic for people's liking, though I think you'll find it fascinating. So this is basically a valve on a stick. It's a self-expanding valve, much like what Dr. Harindra described, but it's done in an open scenario. In this case, the native valve has been removed, and this valve on a stick has been introduced into the valve region there, and the surgeon turns this knob to deploy the bottom skirt of the valve, and then a pin is removed to deploy the upper portion or the frame of the valve, and then the whole system is brought back, and then you have a valve. So basically something that normally takes about 45 minutes to 60 minutes took just about 30 seconds. And this is important because it really reduces the time of the surgery. And we know in cardiac surgery, time is your enemy. So the quicker the operation, the safer the operation, and the better the overall results. So, bottom line, and not only in minimally invasive techniques changing the face of cardiac intervention, but, at the same time, conventional open cardiac surgery is becoming safer and safer, so that regardless of which modality you require, you can rest assured that it can be provided in a safe and effective manner.
Thanks, Gideon. So you've talked a lot about the range of procedures that cardiac surgeons are involved with. So there is a subset of patients that still require open heart surgery. Can you talk a little bit more about how you determine what kind of procedures patients require and what kind of, when do patients need open heart surgery?
So, Sunnybrook is a relatively new program. It was founded by doctors Brian Gilbert and Bernie Goldman back in late 1980s. And I was a product of the U of T system and trained at Sunnybrook as a medical student, as a resident fellow. Now, having worked here for almost 20 years, I've had the unique perspective of having seen this program grow from being kind of the new kid on the block to being one of the most foremost programs in the nation. And when I say grow, I'm not just speaking in terms of size and sheer volume of cases, but perhaps more importantly in terms of impact and national prominence and leadership in the field. So, what sets us aside from the rest? I think personally, it's our culture of collaboration. And I would say we're probably one of the most collaborative programs in the country. And it's because of a culture of collaboration, a philosophy, which was instilled and fostered by many of our leaders, including Brad Strauss, our outgoing program head, because you don't need only leadership, but you need vision as well. And it really flows from the top. So, whereas other programs have clear distinctions between cardiac surgery, cardiology, and vascular services, at Sunnybrook, we've really been able to combine our various talents in a way which provides the greatest benefit to our patients. And we do this by way of something called the Heart Team. So the Heart Team is a multidisciplinary group which includes surgeons, both cardiac and vascular, cardiologists, nursing staff, OR staff, anesthetists, intensivists, support staff, and yes, sometimes administrators. The Heart Team performs a number of functions. First and foremost, the team reviews every case we perform to ensure that we are selecting the most appropriate and the safest and the best case or best procedure for that particular patient. The Heart Team also performs cases together. So for many of our procedures, it's not just one specialist working on you, but often two or three at any given time, each of them bringing a different perspective and expertise to the table, if you will. And then finally, the Heart Team reviews outcomes, both good and bad, to ensure that the decisions we made were the correct ones in the first place. And if not, what do we do to change our processes? And this collaborative culture here at Sunnybrook has really enabled us to become one of the largest structural and most successful programs in the country. It's also the reason that industry wants to work with us and bring us their latest technology, which we in turn can pass on to our patients. It's why we've not only become one of the largest TAVI programs in the country, as Harinder mentioned, but also one of the largest MitraClip programs in the country. And for those of you who are unfamiliar with the MitraClip procedure, whereas TAVI provides a minimally invasive way of replacing the aortic valve, the MitraClip device provides a minimally invasive way of repairing the mitral valve, one of the other valves in the heart. So it's really been an incredible journey for us. And, I would say that, historically, we've done things that have been somewhat unconventional. I'll give you one last story. So back in 2012, when our structural heart program was just starting, because we were dealing with such new technology with little of any worldwide experience, everything we did had an unknown attached to it. And the devices themselves were unpredictable, so much so that the companies would insist that their engineers and clinical specialists were present with us during the early days so they could troubleshoot in the event of device failure or malfunction. They were learning on the fly just as we were. So every case was a new revelation back then. So I remember a case back Christmas Eve, I believe it was back in 2010, when a patient became quite ill and came to our emergency department and was in shock. and needed an emergent procedure, emergent mitral valve repair procedure. And whereas normally we would provide surgery, we recognized that in that particular patient, surgery would come over with a very high mortality or a very high risk of death of probably close to 70 to 80%. So we chose to take a leap of faith and use this new technology, which we had limited familiarity with, in a scenario which we were previously not using this particular device, and which had previously not been reported anywhere in the world. So I called up Eric Cohen, who's my colleague on the cardiology side, and we called up one of the anesthetists. We called up our clinical specialist, who was in Boston at the time. He hopped on a plane and was here within a couple of hours, and we started the procedure. And long story short, we were able to save this patient's life, and actually this patient incidentally became a donor after that as well. So it was an out of the box approach, and the reason we had the guts to try this is because it was a team decision. And I think we made the right decision, but I don't think we would have made that same decision independently.
Thanks, Gideon. That's truly amazing. So we've gotten a really good inside look at what makes the Schulich Heart Program so outstanding. So now I'd like to hear from all of our panelists regarding a couple of other questions that our patients may want to know. So the three of you collectively have performed thousands of procedures. So what do you wish more people knew about their heart health? So why don't we start with Ben first?
Thanks, that's a good question. So something that we have been paying a lot of attention to is exercise and diet, and that's been part of one of our realms of our research. We have a large arrhythmia research group here, and something we've been very interested in is it possible that some of these arrhythmias are potentially reversible if individuals exercise and lose weight and change their diet? And the answer is yes, it is possible. It is possible if someone exercises more. We recommend a minimum of 150 minutes of brisk walking per week minimum. That they can certainly improve their arrhythmia status quite a bit and even potentially reverse it. Some patients cannot do that, and some patients cannot do it because of their arrhythmia. They can't exercise. If they do, their arrhythmia goes too fast. They have to take the drugs which cause suppression of their exercise tolerance. And we've actually studied this, myself and one of my colleagues studied this, and we've written this up to show that we can actually improve exercise tolerance if we perform a catheter ablation. So if we get rid of the arrhythmia, you can actually do an awful lot more. And that overall leads to a better result and better health. So my overall recommendation would be healthier diet, I think Mediterranean, and exercise. And if I had to rate which, I would say exercise is probably the single most important and the easiest one to achieve out of everything.
Thanks, Ben. Totally makes sense. So Gideon, I'm going to ask you the next question, and it's related to COVID-19 because I know this is obviously on top of mind for all of us. So can you speak to how COVID-19 is impacting the heart program? So we know anecdotally, for example, some patients are avoiding seeing their family doctor or going to the emergency department. Is this something that you're seeing in your practice? And what advice would you share with patients who may be worried about coming to the hospital?
Yeah, great question, Rue. It's interesting because I speak to my colleagues in other specialties, and we're all seeing the same thing. Since the pandemic hit, is that fewer patients are being referred. We're seeing fewer patients in the emergency department. And it's true, like I said, just for all specialties, not just cardiac surgery, cardiology. The problem is that the pathology really isn't going away. And rather, patients are learning to live with their pathologies, which is not necessarily a good thing. And I can tell you what we are seeing is we're seeing patients presenting in the later stages of the disease process with far more advanced disease and at times in much worse condition, making intervention far more risky if possible at all. And it always surprised me when my non-medical colleagues are afraid to come near me because I work at a hospital. And, I tell them, listen, my workplace is a heck of a lot safer than your workplace. Every patient that goes to the operating room now gets tested for COVID. Hospital cleaning protocols are more stringent and complete than any of the usual workplaces. Hand hygiene is tracked and is better than most workplaces. So I tell them, if you're okay going into your office building, or if you're okay going shopping at Costco, then you should unquestionably be okay to come to the hospital when the need arises. So my message is, don't ignore and don't procrastinate. If you have a medical issue, come to the hospital. It's as safe a workplace as any.
Good advice. Thank you, Gideon. So my next question actually is for Harindra, and it's related to sort of the fact that we don't deliver care in isolation within the healthcare system. We do it as a system with other hospitals. So can you share some more insights around how we work with others to deliver an integrated approach to caring for patients with heart conditions?
Thanks, Rue. Great question. And I think it really centers on the points that Dr. Cohen made, that the concept of collaboration is such a central part to this hospital and our program. And that includes collaboration not just within the team members of the program, but with our partner hospitals outside. And we take our role as the academic tertiary hub of a group of community hospitals that surround us very seriously. And all of the procedures you've heard about tonight really requires that we work seamlessly with those other hospitals to ensure that their patients are safely transitioning to us. Probably the best example that I can think of that really highlights this is our heart attack program, known as our STEMI program. So 15 years ago, if you came to any emergency room with a heart attack, you'd be diagnosed with your heart attack in the emergency room, you'd be treated there, and then usually after a few hours or sometimes even a few days, you'd be sent to a center like ours in order to have an angiogram to find the artery that was blocked and to fix it. About 10 years ago, 15 years ago, we decided that that wasn't the best way of doing that. And working with our partner hospitals and with EMS, the ambulance service, now patients who have heart attacks are diagnosed right in their house by ECGs done by the paramedics. They initiate a call to our CCU that sends a page to the entire team, and the diagnosis is made in the field. They come directly to us, bypassing all of those other steps, and I meet them for the first time in the cath lab to try to, as quickly as possible, stop their heart attack. And importantly, after that, they go back to our partner hospitals. And all of that is required, really, that we collaborate closely with them. It's required over the last decade, numerous iterations of our protocols, because if you think about it, it's a pretty remarkable thing to diagnose somebody with a heart attack in their house, and within 30 minutes, they are in the operating room having their artery open so that we can stop the heart attack. And that really is an example of a very complex, seamless way of integrating care right across our community. The final point I'd make about this is we've spent an enormous amount of time doing that for our community, but we consider one of our strengths that we are thought leaders both for this province and for this country. And we've actively been involved with both provincial and national bodies so that we can teach others the lessons that we have learned by going through this process, but also importantly, learn from others' experience. And that idea of being part of this larger healthcare system, teaching others what we have learned and learning from them, is really also a central part of our culture.
That's truly excellent. So let me ask another question. And this time I'm going to ask Ben this question, and it's related to arrhythmia services. So you mentioned, Ben, that it's one of the busiest programs. And why is that? And why do you think we're seeing such a growing demand for the specialized treatments that your team provides?
That's a good question. I think the reasons overall are that there are probably more arrhythmias being diagnosed in the community. Our services here are growing exponentially in Schulich Heart, and I think it's because of the fact that we deliver a very high level of technical expertise, and that we incorporate the newest technology which exists. I always say to any of my patients who come into the room, whatever technology I'm going to use is the best you can get anywhere in the world, guaranteed. There is no doubt about it. We do not save on things in terms of trying to go for second best. Everything we do is best. And, you know, I always sort of say as well, yeah, we do a lot of research and innovation here. And I think patients like that. Patients like to go to a center where there's research. I don't want to go to a center where there's no research, because the technology is probably at least 5 to 10 years old. And it takes time for technology to come through the system. It has to go through Health Canada approval. So the things that we're testing in our preclinical lab may be available within the next 2 to 3 years clinically. And a lot of other centers will not even have seen or heard of this technology. So I think that's why we are at the cutting edge of this service.
Thanks, Ben. So my next question actually goes to all three of you, and I'll ask each one of you to respond from your individual perspectives. So, you know, while the future may look uncertain at times, what do each of you feel most optimistic about in terms of your areas or areas of practice? So maybe we could start with Gideon first.
Yeah, thanks, Ruth. So, you know, I'd say I'd answer that from a, you know, specific cardiac surgical perspective, and also from a global perspective. I think from a cardiac surgical perspective, obviously the innovations and the fact that even open cardiac surgery, conventional cardiac surgery, is becoming safer and safer. You know, I would say right now Sunnybrook boasts one of the lowest crude mortalities for first-time coronary bypass surgery in the country, at well under 1%. So that's obviously very reassuring, because we take quality assurance very seriously, and we make every effort in the world to ensure that not only are our procedures effective and timely, but they're also safe. And I would say that we're leaders in quality assurance. On a more global scale, I'd say that the incredible effectiveness of secondary prevention, especially new medications, in stemming the progression of heart disease. Because even after we fix your heart, more often than not, patients remain on medications to ensure that that heart disease doesn't come back. And we know the benefits of diet and exercise, as Ben mentioned. You know, a good friend of mine recently suffered a heart attack, and it caught us all by surprise, because he was young and otherwise very fit and very healthy, and no risk factors. And one of my dear colleagues on the cardiology side, Dr. Eric Cohen, no relation, made a very astute observation. He said that this was a life-saving heart attack. And what did he mean by that? Because this individual, who previously was unaware of his predilection towards heart disease, now received a warning, and will have the benefit of secondary prevention medications and the recommendations, which will likely ensure that he'll never experience another heart attack or cardiac event for the rest of his life. And without this sentinel event, he wouldn't have had this benefit. So, you know, I think we're we're seeing a real change in comparison to me even 20 years ago, in terms of the benefits of medications and stemming the tide.
Ben, would you like to add?
Yeah, I think, you know, I've talked about innovation and how I think that's put us in a very strong position here in Schulich Heart. Other things that I think are very kind of positive when I think about my work are, you know, the pandemic hit us in kind of February, March, and it hit society really hard. And, you know, I sat down with my research team. I have a lot of people that work around me and help me with my research, a lot of students and research assistants. And we actually sat down and tried to figure out how we can manage patients differently, how we can stop them from having to come to the emergency room with arrhythmias. And you know, just having that type of a team around you of people is really amazing and fruitful. I mean that was a very tough time for everyone, as we all remember. And we turned a negative into a positive, and you know, that's gonna, you know, we were like, what are the positives? There are some positives that have to come out of this pandemic. What are the positives? The positives are that we changed the way we've practiced medicine, and maybe that's a good thing. So those are the kinds of things that kind of keep me positive and keep me happy and keep me going. And you know, I'm very happy because I can go to the likes of yourself, Rui, with those ideas, and we can move them forward as an institution. So that's kind of what makes us very different, and I think that these are the things that are going to change the way we practice medicine in the future.
Thanks, Ben. Harindra?
Thanks, Rue. It's a great question, and I think the first thing that pops to mind is also about the pandemic. That the last many months have had a lot of uncertainty and anxiety. The thing that I've felt most positive about is, despite that, or perhaps because of that, we've really seen the resilience of our teams. Really, the idea that we've stuck together when each of us are at different periods of when that anxiety has got to us, supported each other, and thereby being able to support our patients. Being nimble has been such a big part of our pandemic response, but it's also such a big part of being successful in a world that new technologies are coming in and the manner that we're changing, that things are changing is so rapid. And the last few months has really shown that we have that deep in our culture, the willingness not to be stuck in old ways, to be flexible, to be open to new ideas, to adapt to them. And virtual care is a great example of that. That we did it because we needed to during the pandemic, but we realized this is a really good thing, that it's good for patients, it allows us to do a lot of other things, and we've now incorporated that. And we've expanded that thinking of, well, how can we do this in other ways to help our patients? So it really has been an incredible experience being part of a pandemic that hopefully we will never see again in our lifetimes. But I can't think of a time that I've been as proud to be in the healthcare field with people who really have all risen up to meet this challenge. And so that has clearly been, it really has brought to light that pride of being part of this profession and this group.
Thanks to the three of you for those excellent insights. So I have one final question, and it's for you, Harindra, and it's related to the work that you've been doing in terms of health policy change. So you did mention previously that you've influenced policy change at the government level, and specifically as it relates to TAVI procedures, for example. So can you share a little bit more about how you and your team put forward those policy recommendations?
Sure, it'd be my pleasure. I mean, this is an area that I'm particularly passionate about because, as you probably realize from everybody on this webinar, all of us are very excited about new technologies and being able to develop them. But I think it's equally important that new technologies need to reach people, and it needs to reach people in a way that our healthcare system can afford, and there must be equity of access to everybody. That a fundamental thing that all of us as Canadians are very proud of is that everybody is treated and everybody is treated equally. And in order to do that, you need to have policies that change in as innovative a way as these new technologies, that they can't stay behind them. So the ways that we've done that are really twofold. First, a large part of the research that's done at Sunnybrook and done in the Schulich Heart Program is in an area called health services research, which is really looking at the population as a whole, understanding the costs of delivering care, the quality of delivering care at really that big picture level, and understanding what's better, what isn't, what changes can happen. So doing that research, and then taking that research, but also the experience of being at the coal face of care delivery and being involved with policymakers. I would say I accidentally fell into being involved with policymakers, but it has been a consistent reaction that our experiences of being at the front line, combining that with research, has that resonates a great deal. And so I've been fortunate, as have others in the Schulich Heart Program, that we've been part of some of the provincial and national committees that are mandated to make some of these policy decisions. We interact directly with members of the ministry and take this information forward. So really it's research combined with ongoing engagement that has allowed these innovative new policies to be considered, and for us at Sunnybrook to then be the testing site for those. So similarly, for all of the other research where you have a laboratory, you need a living laboratory to test some of these things out. And there's a culture at the highest level of leadership, Rue, you and others, to be willing to do that. And that is so important for the healthcare system. And we really have been the exemplars of doing that.
Yeah, I would agree. I mean, it's such a huge testament to how we are leading the way across the healthcare system and making a huge difference to patients and their lives. So it looks like we're coming up just upon the hour mark. And I want to thank all of our panelists for their fantastic insights tonight. So for an hour, we've gotten to see and to hear from some of Sunnybrook's best and brightest clinicians. And a special thank you to our community for joining us. So Sunnybrook Foundation is honored to have held this discussion with you all tonight. And I'd like you to keep an eye out in your inboxes in the coming days for a recorded video of this session. So feel free to go back and listen to the session again and share it with others. So I hope you come away from this evening with a vision of the new ways we will move forward in cardiac innovation and care. And once more, I'd like to thank you for attending and for your tremendous support of Sunnybrook. Thanks again.